When we talk about brain tumors in children, many people imagine something rare, dramatic, and immediately life-threatening. In reality, some childhood brain tumors follow a quieter, slower, and far more complex course, shaping a child's life over many years rather than through a sudden crisis. One such condition is the optic pathway glioma. An optic pathway glioma develops along the visual pathway, or the structures just behind them in the brain. Although these tumors account for a small proportion of childhood brain tumors, clinicians recognize them as particularly important because of their location and behavior. Doctors most often diagnose optic pathway gliomas in the first decade of life. What makes these tumors distinctive is not only where they arise, but how unpredictably they behave over time. Most optic pathway gliomas are low-grade tumors, meaning they grow slowly and may remain stable for many years. A large proportion occur in children with neurofibromatosis type 1, also known as NF1, a genetic condition that alters how cells grow and divide. In children with NF1, clinicians often detect optic pathway gliomas incidentally during routine imaging or eye assessments, and many of these tumors never require treatment. This experience has taught clinicians a critical lesson. Identifying a tumor on a scan does not automatically mean intervention is necessary. Children present differently, depending on the tumor's location along the visual pathway. Tumors confined to the optic nerve may cause gradual loss of vision, squinting, or protrusion of the eye. Lesions involving the optic chiasm or nearby brain structures can affect vision in both eyes, disrupt hormone regulation, or, particularly in very young children, lead to poor weight gain and failure to thrive, a condition known as diencephalic syndrome. Yet many children, especially those with NF1, show no symptom at all. This reality reinforces the importance of careful observation and regular ophthalmological follow-up rather than rushed treatment. Advances in imaging, especially MRI, now allow clinicians to diagnose and monitor these tumors without biopsy in most cases. Over time, specialists have learned that the tumor size or radiological change alone should not drive treatment decisions. Instead, progressive visual decline provides the most reliable indication for intervention. This shift in clinical thinking has transformed outcomes, helping doctors avoid unnecessary treatment and reduce long-term harm. When treatment becomes necessary, clinicians usually choose chemotherapy as the first-line option, particularly in young children. Regimens such as carboplatin combined with vincristine or vinblastine alone often stabilize tumor growth and preserve vision while delaying or avoiding radiotherapy. This approach is crucial because radiation therapy in young children can impair cognitive development and significantly increase the risk of secondary tumors, especially in those with NF1. Surgery plays a limited but important role because optic pathway gliomas intertwine with delicate visual and hypothalamic structures. Surgeons rarely achieve complete removal without causing profound visual loss. For this reason, surgeons reserve operations for specific situations, such as relieving raised intracranial pressure, managing hydrocephalus, or removing tumors confined to a single optic nerve when vision in that eye is already lost. In these cases, the goal is not cure, but preservation of overall neurological function and quality of life. Over the past decade, advances in molecular biology have opened a new chapter in treatment. Researchers have shown that many optic pathway gliomas arise from abnormalities in the MAPK signaling pathway, often involving BRAF alterations. This discovery has driven the development of targeted therapies, particularly MEK inhibitors such as selumetinib, as well as combinations like dabrafetinib and chamatinib. Taken orally, these agents have demonstrated encouraging results in controlling tumor growth and, in some cases, stabilizing or improving vision, while reducing long-term toxicity compared with traditional treatments. These newer therapies carry their own risks, including skin reactions, cardiac effects, and ocular complications. Nevertheless, they mark a clear move toward more precise and personalized care. Many of these treatments remain under active investigation in clinical trials, underscoring how rapidly the management of optic pathway gliomas continues to evolve. Decades of research and clinical experience now convey a clear message. Optic pathway gliomas do not represent a single disease, and they do not demand a single response. Some children need nothing more than reassurance, careful monitoring, and time. Others require chemotherapy, targeted therapy, or a coordinated multidisciplinary care to protect vision and long-term development. Survival rates remain excellent, but true success lies in preserving sight, cognitive growth, and overall well-being. For the public, this story offers hope, balanced by patience. For students, it illustrates the value of clinical judgment over reflexive intervention. And for specialists, it serves as a reminder that the future of neuro-oncology lies not only in treating tumors, but in understanding and protecting the child who lives with them. Thank you for listening, and have a blessed day.